The next speaker is Dr. Jeong Hyun Lee, with the title of Clinicopathologic Characteristics and Prognostic Factors of Superficial Soft Tissue Sarcoma.
Good morning, everyone. My name is Jeong Hyun Lee from Seoul National University. I will be presenting our work on clinical pathologic characteristics and prognostic factors on superficial soft tissue sarcoma. Superficial soft tissue sarcoma refers to as soft tissue sarcoma which has its center as subcutaneous layer. Due to its superficial location, early detection leads to favorable outcome in many patients. However, some has grave prognosis. Therefore, it is important to identify its prognostic factors, but only few published studies dedicated to superficial soft tissue sarcoma are available. Orange mass represents sarcoma and blue dotted line represents fascia. Unlike deep soft tissue sarcoma, superficial soft tissue sarcoma is surrounded by well-defined, rather simple anatomical barrier. It is surrounded peripherally by subcutaneous fat and the fascia, the rigid natural barrier that blocks sarcoma's penetration into deep tissue. Tail sign, which is an infiltrative spread of tumor along the fascia, can be identified on MRI. It is most readily identified in superficial soft tissue sarcoma, but the oncologic outcome significance of tail sign is unknown. So this study aimed to evaluate oncologic outcome and to identify prognostic factors, focusing on unique MRI features such as tumor's relationship with fascia and tail sign. Among 289 patients who underwent surgery for superficial soft tissue sarcoma, 33 cases were excluded because of short follow-up, and one patient with concurrent chondrosarcoma was excluded, which left with 253 for analysis. Medical records were reviewed for potential factors that might influence oncologic outcomes: patient characteristics, tumor characteristics, and treatment characteristics. For patients' demographics, 45% of patients presented to our clinic after unplanned excision, and 16% with local recurrence. Median follow-up period was 4.5 years. For tumor characteristics, undifferentiated pleomorphic sarcoma and mixed fibrosarcoma were the most common histological subtype. Median tumor size was 3.75 centimeters, and 17 cases presented with metastasis at diagnosis. We categorized tumors' relationship with fascia in MRI. First, no fascial contact. Second, fascial contact. Some regions of tumor have fascial contact, but tumor does not cross the fascia. This is example of corresponding MRI image. Lastly, when the tumor crosses the fascia, we classified it fascial invasion. And tapered fascial enhancement extending from the tumor margin with more than 1 millimeter thickness was recognized as tail sign. For treatment characteristics, wide margin was achieved in 84% of cases, and negative pathologic margin was achieved in 93% of cases. 13% received chemotherapy and 45% received postoperative radiotherapy. Oncologic outcomes analyzed were disease-specific survivor and local recurrence-free survivor. Univariate analysis was performed with Kaplan-Meier survival curve with log-rank test, and multivariate analysis was evaluated by Cox regression. Now the result. Among 236 patients, 39 patients died of disease, and disease-specific survival rate was 83% at 5 years. Univariate analysis revealed older age, higher histological grades, larger tumor size, fascial invasion, and positive pathologic margin as prognostic factors of poor disease-specific survivor. In multivariate analysis, older age and fascial invasion remained significant. As for local recurrence-free survivor, 48 patients had local recurrence, and 5-year local recurrence-free survival rate was 78%. Univariate analysis of variables showed that old age, presentation other than fresh, fascial contact, and positive pathologic margin had higher risk of local recurrence. Only age and presentation remained as independent variables in multivariate analysis. To summarize, good oncologic outcome can be expected in a substantial number of superficial soft tissue sarcoma patients. Older age and fascial invasion on MRI are associated with worse disease-specific survivor, and older age and presentation after unplanned excision or recurrence increased risk of local recurrence. In conclusion, unique characteristics of superficial soft tissue sarcoma can serve as useful prognostic factors in addition to the established factors. These findings suggest the necessity of a different assessment strategy for superficial soft tissue sarcoma. Thank you very much for your attention.
I thank all the speakers, and if there are any questions from the audience, yeah.
I'm Yoshihiro Araki from Kanazawa, Japan. I have a simple question for the first speaker. Did you confirm the surgical margin in unplanned excision specimen? First speaker. Did you confirm the surgical margin in unplanned excision specimen?
There was no significant difference in resection margins between the two groups. One limitation of our study was that we did not assess whether in the resection specimens there was still residual tumor. So we had wide margins in most of the unplanned excision cases, I guess, because there was no residual tumor left.
So you mean you include both surgical margin positive and negative cases in your study?
Yes, we had resection margins from R0 to R2.
Okay, thank you.
So while we wait for the next question, I would like to ask a question to Dr. Greimer and Dr. Andreas. I mean, what direction do you think your study is taking us to, as to the follow-up of soft tissue sarcomas?
That, of course, is the key question. And I think Andreas and I would both agree that this is leading to personalized follow-up in the future. Rather than one size fits all, we will very soon have a nomogram that's on an app that will tell you what the risk of your patient having local recurrence and metastases is, and you can then discuss it with the patient. It might even tell you what value finding those metastases is, because if you have, say, a synovial sarcoma which you can give chemotherapy to, you might be more aggressive to follow them up than something which in a 75-year-old is going to be non-responding to everything, and you may decide with the patient you don't follow them so aggressively. It's interesting, we did a study in the UK asking patients how intensive they would like follow-up to be with varying risks of metastases, and at every level above 1%, they said they would like very high follow-up, but below 1%, they said, oh, I'm not worried. But then when we told them that the risk of getting another cancer in the same year, once you're over 65, you've got about a 3% risk of getting cancer, they scratch their heads a bit there.
So it's personalized medicine and personalized follow-up now. We're moving towards
that. That will be the future. And Andreas will do it. He has very clever statistics.
Right.
Beijing, China, for the first speaker, the lady. So my question is that in your series, for the unplanned excisions, so after surgery, what is your timing choose for the second surgery? How long? 1 month, 2 months, 3 months?
It was about 30 days. So the mean time interval between primary resection outside and then re-resection at the tumor center. And we discovered no significant difference in overall survival, because this has been discussed in literature very often that a longer delay leads to the higher rate of local recurrence, but we didn't discover that in our series.
So, and the second question is, so for the second surgery, will you use the MRI, right? MRI. Mm-hmm. Will you use T1 or T2 or T2 fat suppressed? So which image sequence will you choose for? We
usually use all sequences and also with contrast agent.
So for the edema, will you cut it down?
We had
the edema area, will you cut it down? Okay. All of them?
We usually do an MRI scan.
I mean, if after the first surgery, all edema area that contaminated the all area, will you cut all of them?
We don't resect the whole edema, but we use radiotherapy for the whole edema area afterwards. So there's a high percentage of radiotherapy given after the operation also to the edema area. Because sometimes you have post-operative edema and it can go the whole leg down, and we don't do amputations then or big.
We have time for one last question there. Yeah.
Lester Chan here from Singapore. Just to follow on to that last question, we cut the whole edema out, and often we will amputate if we can't get that clearance. My question is for Dr. Lee regarding his study with tail sign. Have you tried to correlate your MRI tail sign with pathological findings? A second part to that, do you use what is your radiotherapy protocol? And do you use radiation in all of these tail signs, or selectively for certain cases or for all cases?
Okay, thank you for the questions. In our study, we didn't compare it with pathological report, but at our institute, there was a paper written by radiological department, which it compared both pathology and radiological images. And in that report, there were some correlations. And for the treatment, we decide whether we do...
Is it a good correlation between what you see on it? I mean, how often is it just edema, and how often is it really cells that you can see? And is that affected by your radio?
I think we can continue the discussions later on. If you can answer the question, we can conclude this session. I thank all the speakers and the audience for their active participation. The time is up, so the session is concluded. Thank you.